Assalamu alaikum wa rahmatullahi wa barakatuh. Today I'm going to talk about pre-implantation genetic diagnosis. So for a successful IVF, it is based on, in part, on successful selection and transfer of healthy, viable embryos. Initially, embryo selection was performed by examination of the embryo appearance under the microscope, and this is known as morphology assessment. However, it became clear that many embryos with a normal appearance under the microscope were not able to produce live-born baby. So what are the causes of IV failure? Many normal appearing embryos have abnormalities in the number of the chromosomes, which is called aneuploidy. And these abnormalities are the leading causes of IVF implantation failure and spontaneous miscarriage. What is pre-implantation genetic diagnosis then, and why we are going to discuss it? PGD is a specialized technique that is designed to help couples who are at risk of having a child with a specific genetic condition or a chromosomal disorder. It gives these couples an alternative option to prenatal diagnosis, which involves the testing of natural pregnancy. And if you remember that in a prenatal diagnosis, it can be performed on chorionic villus sampling from approximately 12 weeks gestation and carries a 2% miscarriage risk. Couples having PND might then be faced with the difficult decision of terminating an affected pregnancy. So might you ask, what is PGD and for whom it is available? PGD is available for couples who have had previous affected children and or in the case of chromosome rearrangement, recurrent miscarriages, or infertility. So I want you to emphasize on this. And undergoing PGD is a complex process involving attending several appointments, blood tests, scans, completing many consent forms and other tests over several months, and it can be both stressful and emotional. Provisional support and counseling are available throughout the process, and the average time scale from referral to commencing hormonal treatment is currently around 10 to 12 months. So, whom are you going to apply PGD for? Those patients with single gene disorders, X-linked disorders, chromosome translocations, numerical chromosome abnormalities, other chromosome abnormalities. And who will mostly benefit from these? Couples with recurrent miscarriages, women of advanced reproductive age, implantation failures, and genetic male factors. Somebody might ask, what is the difference between PGS and PGD? Pre-implantation genetic screening, or PGS, it employs the screening of embryos to ensure that 23 pairs of chromosomes, including 6 chromosomes, are present and there is no aneuploidy. While pre-implantation genetic diagnosis, the PGD, diagnosis of embryos for a known genetic disorder that both the patient and the partner are carriers for of conditions such as sickle cell disease, thalassemia, etc. In some centers, eligibility for PGD is very strict. Theoretically speaking, the best results are obtained in a known case of genetic condition in the family, which conveys a significant risk of a serious genetic condition, no living unaffected child, or untested child for an adult onset disorder as a couple. Female hormone level, that's to say the anti-Müllerian hormone, of 7.5 picomole per liter or greater, or an adequate ovarian scan. Female age less than 39 years, female body mass index less than 30. Both partners should be non-smokers for at least 3 months, living at the same address for at least 2 years, and PGD is better not to be offered to patients with a de novo dominant mutation. What is the protocol of PGD? An oocyte or many oocytes are aspirated following ovarian stimulation, and these are fertilized by in vitro immersion in semen, IVF, or by intracytoplasmic injection of an individual spermatozoon, the Cgh, you know much better than me. Pre-implantation cleavage stage embryos are biopsied, and usually by the removal of a single cell on day 3 post-fertilization, and the biopsied cell is tested to establish the genetic status of that embryo. So the types of biopsies can be, as we said previously, in 3 days, but there are many modalities. For instance, polar body biopsy, cleavage stage biopsy, and a blastocyst biopsy. And here are different examples of biopsies. You can see here the polar body, and here from the 8-cell stage, and here from 4-cell stage, and here from a blastocyst. The first type of PGD was accomplished by the application of fluorescent in situ hybridization, what we call the FISH technique. And this is done by FISH technique applied on the fixed nuclei of biopsied cells, which target specific DNA probes. And this technique is of choice, of course, to detect chromosomal imbalance associated with chromosome rearrangement, and to select female embryos in families with X-linked disease for which there is no mutation-specific test. FISH has also been used to screen embryos for spontaneous chromosome aneuploidy, as it known as PGS or PGD-AS. The protocol of FISH technique involves important steps, and these are the lysing and spreading of a nucleus from a biopsied blastomere, then application of in situ hybridization of a single blastomere nucleus, then the analysis using fluorescence microscope, suitably equipped with appropriate filters for the probes which are used. And you can see here that the biopsies are being put on the slides. Here you can see fluorescent in situ hybridization for trisomic chromosome 21 and chromosome 18. And this is an indication of a complex aneuploidy in a cell, and this is very much contraindicated for successful IVF. For FISH PGD, there are certain limitations, such as it can only test a minority of chromosomes, which may omit other chromosomal aneuploidy. Large-scale studies fail to find an improvement in the chance of live birth using FISH from biopsies at the 8-cell stage. As a consequence, this type of testing has become largely obsolete. Nowadays, it has widely been replaced by more advanced techniques, including chromosome microarray analysis or next-generation sequencing, what we call NGS. For comparative genomic hybridization using microarray, It is now widely applied for comprehensive chromosome screening. Clinical studies have demonstrated improved IVF outcomes, resulting in a reduction in the time to achieve a healthy live birth and a reduction in the rate of miscarriage or a profoundly disabled child due to an abnormal number of chromosomes. What is Cgh? It is a molecular cytogenetic method for analyzing copy number variations relative to ploidy level in the DNA of a test sample compared to a reference sample without the need for culturing cells. And you can see here there is comparison between the patient in green and the reference in red, and these are hybridized to certain props, and different signals are given in green, in red, in yellow, and meaning that for instance in yellow spot there are the signals for both the patient and control with 2 copies. The green spot will give me 3 copies for the patient and 2 copies for the control or the reference, and a red signal will give me 1 copy of the patient and 2 copies of the control. This is an example of monosomy, and this is an example of trisomy, while this is a normal diploid baby. Cgh also has certain limitation. For instance, inability to detect structural chromosomal aberrations without copy number changes such as mosaicism, balanced chromosomal translocations, and inversions. Cgh can also only detect gains and losses relative to the ploidy level. If there is a ploidy, it can gain. But if there is no ploidy, there is no any ploidy, it cannot show me the difference. The limited resolution of metaphase chromosomes aberrations smaller than 5 to 10 MB cannot be detected using conventional Cgh. And the main disadvantage of array Cgh is its inability to detect aberrations that do not result in copy number changes and is limited in its ability to detect mosaicism. So when you have a baby with the mosaic picture, Cgh is not enough. Now, what is the solution then? It is the application of next generation sequencing, or the NGS. It is a new technology of comprehensive chromosome structure of IVF embryos. Next generation sequencing for PGD is likely going to replace other technologies as the predominant method for pre-implantation genetic screening. What are its potential advantages? Reduced cost, enhanced detection of structural abnormalities such as chromosomes with missing or duplicate segments, better ability to detect when an embryo may have cells with different results, that's to say mosaic baby, or reduction of human errors by increasing use of automation. The workflow of NGS involved the biopsy of a blastocyst. Then it is put in a test tube to undergo lysing, and then the product is targeted by what we call site enrichment, which is enhancement on enrichment of the chromosome we are going to detect. For instance, if it is only a single gene mutation, it is also beneficial to do the target enrichment. Then undergoing what we call a low-depth NGS, which is sequencing of the genome. So you can detect monogenic disease, you can detect CNV for aneuploidy, and you can detect single diseases by linkage analysis. In general, having been well known, are there any risks of PGD? Yes, there are risks involved with PGD, including the risk of ovarian hyperstimulation by hormones, the risk of poor response to the fertility drugs, and there is a small risk of a multiple pregnancy even when only one embryo has been transferred, and a small risk of misdiagnosis. Thank you for listening.